going to take a break from talking and I'm going to hand it over to Ken Martin. He is a physical therapist from New Orleans, Louisiana, with extensive experience in outpatient orthopedics, sports medicine, home health, nursing homes, private practice, and manual therapy. He earned his undergrad degree from Southeastern Louisiana University and his physical therapy degree from LSU MC School of Allied Health. Ken has spent 26 years with Anatomical Works, where he focused on manual therapy and continued advanced training through Michigan State School of Osteopathic Medicine and the St. Augustine School of Manual Therapy. In 2022, he joined the Louisiana Bleeding Center for Clotting Disorders team, where he brings his expertise to patients with bleeding disorders. Outside of work, Ken enjoys traveling, sports, music, spending time with his friends, and being with his 2 young adult children. Thank you, Ken, for being here, and take it away.
Thank you, Amy. I appreciate that. Actually, that was a very thorough and presentation. You did probably more than half of my presentation, so this is going to be quick. Anyway, can you see my screen? Wait, what am I doing? Can y'all hear me?
Yes.
Okay. All right.
We can see it.
Okay. So you really touched on a lot of good bases and points there with bleeding disorders. You covered really a lot in depth, so that was really a good presentation. So I hope I don't repeat anything on my slides, but we'll go through them and see. First of all, objectives is to understand the role of a physical therapist within the bleeding disorder clinic, understand the cycle of a joint bleed, which you touched on a little bit, and understanding the elements of PT assessment treatment of a joint bleed throughout all stages of the bleeding process. So the one thing that's important to know is that as a physical therapist, the main thing that we do for patients that come into our clinic, whether they have a bleeding disorder or not, is to improve their functional levels. That's the most important thing. You may be limited in range of motion, but with that limit in range of motion, you're saying your knee, your gait's not going to be 100%. So you lose function with mobility, with gait. It may even affect your job, such. So working on function is very important. Like I said, even with patients that don't have bleeding disorders, but especially with bleeding disorders, because of the hemophilic arthropathy that they can develop that you had spoken about earlier. So also wellness and fitness, that's important too, to continue it, and the quality of life related to movement and health. Again, you have to have range of motion. Once you have range of motion, you have to have strength. Focus on preservation, enhancement, restoration of either physical function or wellness or quality of life. So that's all important when we see these patients, and we get them at all phases. We treat infants as well as adults. So you catch them early enough, you can educate them as far as preventing bleeds from happening. And you can follow through and see what their life expectancy of their joints. And using ultrasound is one of the tools that we do to identify the health of the joint and early onset of any type of hemarthrosis in the joint. Let's see. We serve as the musculoskeletal experts in the field of bleeding disorders, and the providers rely on us to help identify a bleed, if it's an active bleed through point of care ultrasound, or just the general health of the joint. We also educate families. That's the most important thing as far as prevention and identifying a bleed, what it looks like. We also have a book that we give our patients called Playing It Safe. So it's regarding recreational and sporting activities. It's really a good book, and it tells you the high risk and low risk of sporting activities that our patients can do. We do have bleeding disorder patients that play basketball and baseball. Of course, we don't like any type of sports like football, contact sports. We really don't like our patients in a bounce house or trampolines, because we really want to prevent cranial injuries or cranial bleeds. But education is one thing that we do, and we educate on identifying a joint bleed, which you already talked about with the swelling, the loss of range of motion. Some may or may not bruise, but also pain. Now, some patients say it feels like a burning, bubbling pain or sensation in the joint. Not everybody will feel that, but that's one of the things that they do tell me when they do have a bleed. We also are able to recommend orthopedic consultation with a patient, and we also refer out for physical therapy with our patients here. PT, hemarthrosis, this is the frequency of it, 70, 80%. Most common in the hinge joints, which are the ankle, knees, and hips, and the elbows, rather. Those are the hinge joints that you see most of the bleeding occurring. Less common are the shoulders, wrists, and hips. Muscles account for about 10 to 20%, and all other major bleeds about 5 to 10%. Of course, cranial nervous system, you got to be careful with those. Any, as it said, blood supply can bleed. So mainly into the brain, you got to be careful of cranial bleeds. That's why we don't like any type of trampoline or bounce house activity with that. So y'all probably know this already, the different classifications. You got type 1, below normal levels, type 2, normal levels of factor, but factor fails to work properly. Type 3, total or near totally quantitative deficiency of factor. They severe, like Amy said, 2% of the population. Mild to moderate is 13, and then mild to moderate type 1 is 85%. Of course, you got the subtypes that are here too. A lot of the BWDs will be identified usually with nose bleeding or mucocutaneous bleeding that occurs, nosebleeds, bruising, and such like that. But they are difficult to diagnose. This basically shows the complex diagnosis of the phenotypes Amy talked about. Variable levels can be caused by stress, exercise, hormones, blood grouping can impact the VW factor, as well as burdensome bleedings, as they call it, recurring, prolonged, excessive bleeding may lead to reduced quality of life. We talked about losing function. Also, managing surgery is another thing. Close monitoring, enhancing hemostatic management is necessary with VWD patients, not just hemophilia, but you want to manage it pre, during, and post-surgery. Okay, that's very important to prevent any bleeds from occurring. The rationale for prophylactics in VWD, and this is a lot that our providers will talk about, but I thought I'd just present it. But joint bleeds may lead to developmental arthropathy, particularly in type 3 VWD patients. Also, bleeding can jeopardize quality of life, could be life-threatening. Prophylaxis, VWF concentrates can reduce bleeding rates. Prophylaxis can reduce the burden of VWD, improve quality of life. So it's very important that they get on prophylactic sooner than later to prevent bleeds. And that's one thing that you can teach a patient is adherence to their factor regime, whatever the provider says, it's important. Now, this, I'll go real quick. This just shows typical clotting with a bleeding disorder here. With this graph, I'm sure most of y'all know this. So this is normal way you see the platelets, the capillaries tighten up to slow the bleeding down after an injury occurs. And the clotting factor in the plasma work to form a clot to stop the bleeding, as you can see in this top one. Down here, it shows that the factor is missing, so portion of the cascade of the table is going to miss, and the bleeding continues. Now, you don't bleed more, you just don't stop bleeding. A lot of people have a misconception that they just keep bleeding to death, but obviously it's not true. You just don't stop. So this is the pathogenesis of hemophilic arthropathy with hemarthrosis of the joint, as Amy touched upon. But chronic synovitis is a problem. We see that a lot with our patients. So the synovial responds to repeated bleeding events by it becomes thickened every time it bleeds like this, and the blood lyses, and the cell You also can develop the muscle atrophy, which you lose a lot of strength and muscle tone surrounding the joint. You can get instability as well, and also cartilage degradation. So that's what, when you have hemarthrosis in the joint, it causes degradation of the osteochondral structures. Okay. So that's why you want to try to prevent it. But if you do have a bleed, you have to take your factor. That's the important part of it. And treat it with rice, which Amy touched upon too. Let's see. Tell me if I'm running a little too long. Chronic long-term effects. Okay, you can develop synovitis. Sometimes our doctors will do a synovectomy because once you have that synovitis and it thickens, it keeps getting pinched, which will continuously cause a bleed. Sometimes bleeds are caused by either injury, activity levels, also spontaneous. Sometimes they're just spontaneous bleeds for no rhyme or reason. It just happens. And the severity, like Amy said, it could happen where people that are severe hardly bleed, and people that are mild bleed more. And so you can't really go by that. Again, Amy showed you this picture here, what happens. And this is talking about a target joint, which is the same joint bleeds 3 to 6 month period, 3 or more bleeds. They call it a target joint. Let's see. Again, basically a bubbling, tingling heat is what they say. They feel like swelling, pain, obviously a boggy, swollen thing. They'll define it. Muscle wasting. You get morning stiffness, chronic pain, limited movement with a bleed in the joint. Now, this is, again, when it gets to this point, you got swelling in the tissue. They become permanent. When it gets to this point, this is usually when you need a total knee replacement. I've seen a lot of these, but sometimes in the early phases, you can go ahead and get a synovectomy, which may help stop the bleeding and increase the range of motion and decrease the pain as well. Muscle bleeds are important too. That can happen just as well as a joint bleed. The same symptoms. You would have redness. It may or may not bruise, swelling. You'll feel warmth. It's painful. The most important one is the iliopsoas bleed. Okay. This is your hip flexor, your primary hip flexor. This is the one we tell our patients, if you think you have a iliopsoas bleed, to go to the emergency room, because you can get permanent nerve damage from this in the femoral nerve. You also can develop what's called compartmental syndrome in the muscle, where there's a lot of pressure and it's very tight and very painful, with a compartmental syndrome too. So iliopsoas bleed, this is important. Signs and symptoms: you flex your hip. You cannot, if you're standing erect, you cannot stand totally erect in your trunk. You have to lean forward to relieve the pressure. You also have back pain. When you're laying supine, you cannot straighten your leg out. You have to flex your hip. Those are the two main signs of an iliopsoas bleed. They're very painful. It's different from a joint bleed in the hip. You don't have that. You're able to bend or straighten your leg out with a joint hip bleed. That's how you can differentiate between the two. So that's an important point there. So this is what a muscle bleed looks like. And this is an ultrasound. I looked at it. I don't know why I didn't put ultrasound pictures of the joint, but this is a muscle bleed. It's a gray matter with the ultrasound. This is the quad muscle. You can see the fibers here, but down here is where it's disruptive. And you got this blood here that is formed with fluid too as well. So you got interstitial fluid plus a bleed right there. This is something that can develop in muscle bleeds. I just threw this in here. I think it's important. It's called myositis ossificans traumatica. This is from when you get, say, somebody runs into you in your thigh, or from any other injury, that a bleed or a hematoma in the muscle can calcify and become hard. And it's called OHR, heterotropic ossifican They can dissolve or resolve in about 12 weeks. Sometimes if it gets really bad, the doctor will go ahead and cut it out, but it's usually detected about 3 weeks post injury, and it feels like a hard calcified knot in the muscle. So you want to pay attention to those things. Modalities will help it. For physical therapy is really good for it. A TENS unit, any type of electrical stim, ice, heat, gentle massage will help that as well. So this can happen with anybody. All right, this is some joint bleeds, what they look like, and I'm sure these are really involved here. You got a reflex inhibition of the muscle, so that basically shuts the muscle down. It won't work when you have swelling like this in the joint, okay? These are just some pictures. Again, this is without prophy. Here's some other joint bleeds. You can see the deformity here. This looks like, this is the elbow. It almost looks like an electrolyte bursitis, but it's not a bursitis. It's blood sitting in that area, in that posterior elbow. So these are interesting images, and hopefully nobody ever had something like this. But this is the bruise. Some do bruise, some don't. This one's not bruised, but this one's bruised. You can see the difference. So don't always rely on bruising or redness as how to identify it. Again, some other joints, ankles without factor. So the sign, telltale sign when somebody walks in the clinic that they have a bleed, but it's not always a bleed. Sometimes it's synovial fluid or synovitis that can swell up like that and cause the inflammation. This is a factor they use. It's Hemlibra, but it shows an injury after you're on a factor like Hemlibra or something that will help with the swelling. So we can pass these up here. Okay. X-rays. Unfortunately, I didn't put the ultrasound in these slots for some reason. But this is, I can blame it on Derek, our IT guy. These are X-rays of what hemophilic arthropathy looks like. You can barely see the joint line. Here's the knee. Can't even see the medial or lateral joint line, barely. And this is all from a bleed, not osteoarthritis, which is the difference, okay? So more arthropathy in the ankle joint. So again, y'all probably know this one. VWD is the most common bleeding disorder. Affects 1% of all U.S. citizens. It also occurs equally in men as it does in women. And say, for instance, comparison with hemophilia, it occurs mostly in men. Again, you know the different types and the subtypes of two. Also, you got to be careful of GI bleeding with this. All right, PT assessment. Again, just any patient that walks in with a bleeding disorder, we want to check for synovitis, crepitus of the joints, temperature, shoulder range of motion, all the different joints. You want to test that. You want to test their strength with manual muscle testing. We test posture alignment, balance, fall assessment, gait analysis, and the main thing is functional activities, age-appropriate skills. Obviously, cognitive and motor development in a 2-year-old as opposed to, say, a 10-year-old. So we assess this when they come in. Impairment levels, we do girth measurements. Again, active, passive range of motion. We do the hemophilia joint health score. It's a way to see what the joint restrictions are and if they're prone or have had bleeds. And a lot of clinics use this that don't have ultrasounds to be able to identify a risk of a joint bleed. These are different types of stress with the knee where you're testing the medial and lateral valgus. Muscle strength, again, functional strength, different from muscle testing or manual muscle testing. Leg length discrepancies and such. So it's the same thing we do with normal patients in physical therapy, but we pay really a lot closer attention to their joints that might have had bleeds in it. Again, adherence to the prophy is the number one thing that we try to educate our patients and sticking to their regimen. This is very important. Pain management, we will refer off to pain management if it gets to be really severe. We do some adaptation, modifications, equipment management. If they need braces, orthotics, I do test a lot for evaluate for orthotics. if they need them, wheelchairs, walkers, any type of assistive device, also exercise programs. That's important. We just don't do a cookbook exercise for everybody. We gear it to that person's lack of function or strength. Again, Amy touched on this. We use kinesio taping, gait training, and also manual physical therapy. My background is in manual therapy, so I do use a lot of techniques with manual physical therapy with these patients that has really, I've had some success with it as far as helping with their pain and increasing their range of motion. This is what Price, it used to be called Price, now it's called Police. Price, you protect, obviously, utilizing pillows and splints, but O is offload, meaning you limit no weight bearing, no bearing weight through extremity recommendations vary based on bleed type. So this is a little different because you want to offload it, but you want to exercise it, but offload, meaning you don't want to load the joint with weights or anything like this. But it's almost like doing ankle pumps, okay? Just while you're slowly doing this with your ankle, dorsiflexion, plantar flexion, as it's called, to help that circulation to occur and help with movement and not letting it get too stiff. Again, ice, 10 to 15 or 20 minutes every hour or two, compression, you wrap it in elevation. So they kind of modified that. Okay, offload, this is what they're talking about. This is just an analogy of a sponge here, but about bleeding and healing takes time, a long time. So even though you're feeling a little bit better and the swelling's going, you're still at risk of injuring that joint or causing a rebleed. It takes 10 days for the blood to totally reabsorb. So you got to be careful with patients that they don't become overactive and cause a rebleed. Again, signs of a hemarthrosis. Amy went over this very well. Edema, warmth, very painful. You know the signs. Subacute hemarthrosis. This is just resolving the bleed, what you have. Again, you can start with isometric exercises, gentle active range of motion exercises, gravity eliminated, gradual strengthening exercises. You can initiate weight bearing in a pain-free range. So you want to go ahead and start working in the subacute phase. You got to continue your factor replacement as recommended by the provider. You want to also continue measuring the girth, especially around the muscle, to see if the swelling is going down. So this is what we call a subacute hemarthrosis. And this just shows active range of motion, which you need for swing phase and gait to walk. You need 67 degrees of flexion, 83 degrees to ascend stairs, 93 degrees to rise from a chair. So this is range of motions that we try to achieve with patients when they come into the clinic. Again, bracing is something that we can do, immobilizing joints, using splints, using slings for the upper extremity, non-weight bearing, if it's a weight bearing joint with crutches, walker. So it's important you don't let them get up and walk too soon with a bleed. Again, intervention that we talked about, these are all the different exercises we can do. Closed chain, eccentric exercises, open kinetic chains. You want to avoid high repetition and high load exercise. You don't want to load that joint too much. Gait and balance training is always important. And I will assess their balance when they first come into the clinic. And I think we do a Berg, what's called a Berg balance assessment. I think when they say when they're 27 years and older, that's when you should start assessing for balance or risk falls. So these are the things we do in intervention, and this will be it. So, okay, any questions? Thank y'all. I kind of rushed through that. So like I said, I know Amy did a lot of covered the same things, but she did a better job than I did.
Yeah. We're going to do some questions. If you can just sit tight, we're going to do some question and answers towards the
Okay.
end. Does that sound
Okay.
good?